installment of the School of Health Professions Dean's Lecture Series that's focused on skills beyond discipline-based expertise. And the underlying premise of that is that obviously people come to Downstate, all of our students, to learn primarily clinical skills, with the exception of those in the graduate school who are getting advanced research skills and those in public health. But in order to really be a leader in your field, my argument is that you have to have something in addition to those clinical skills. And so these are the kinds of skills that I'm talking about in terms of those things, in addition to discipline-based expertise. So tonight we're talking about intercultural competency, and you may recall that last year the entire School of Health Professions Dean's Lecture Series was focused on cultural issues. So tonight will be just a little bit of a conversation about what we talked about actually for 9 sessions last year. So keep in mind that we do our 30-30 format. The first 30 is me giving an overview of the content in a given topic area. And then the second 30 is for us to have our conversation and discussion. So I've shared my screen. Hopefully everybody can see it. I just have three slides tonight, including the topic slide, which is the title slide, which you're looking at right now. And then I'm going to advance to the main slide. At this slide and a key model that I'm going to show you in a little bit. But really want to talk about 7 things tonight that relate to intercultural competency. I call these the key concepts, the key things that you want to know in terms of working across cultural lines. So intercultural competency really means working across cultural lines. And so the first topic here is concept of culture and its dimensions. So in the United States, I think it's safe to say that we have a preoccupation with the cultural dimension related to race and ethnicity. Because typically when you say cultural dimension, people almost immediately think about race and ethnicity first and foremost. And that's for 2 reasons. One, because of the slavery experience in our country, where those who were enslaved and those who did the enslaving were differentiated based on race and ethnicity. And the other issue is, the other reason that we have a preoccupation as Americans is because race and ethnicity are the 2 primary dimensions of culture that one can, without even interacting with a person, can just see a person and make a judgment about. And that judgment about what group that person belongs to in terms of race and ethnicity may not be correct, but you can certainly make that judgment based on visually seeing another person. Again, you may not be correct in your assessment, but you can make that judgment. But there are many other dimensions of culture, such as spiritual or religious orientation, gender identification, sexual orientation, political affiliation. Clearly, Republicans and Democrats have different views on things. Socioeconomic status, the very wealthy and those who are very much impoverished. Cultural identity based on discipline or profession. Clearly, occupational therapists see the world through one set of lenses, and then of course PAs and other health professionals view the world somewhat differently. So with culture, we're really talking about the concept of worldview, values, assumptions, lifestyle characteristics, ways of getting through the world. So culture is a dimension that both brings people together who share those similarities across those lifestyles, those values, those assumptive forms, that those are things like dress and the kinds of things that we assume that give you a clue as to what our cultural orientation is. Sort of like the dress that you see in the Orthodox Jewish community. That would be an assumptive form that kind of keys you into that part of who they are in terms of their cultural identity. And so culture really is those things that are synonymous with a group, but that differ across group lines. So it's both a concept that brings people together within the same culture. It also differentiates people across cultural lines. Now, the reality is that we make a big fuss about culture in terms of race and ethnicity, religion and spiritual orientation, and all the other traditional dimensions. But the reality is that we're all very different culturally on an individual basis, because each one of us has many cultural identities. For example, I have a cultural identity as a Black male. I have a cultural identity as a person who lives in Brooklyn, at least part of the time. I also live in Virginia. I also have a cultural identity of my own discipline, the various things I've studied in school. I have a certain socioeconomic status strata that I'm a member of. I may have a political affiliation. I may have a spiritual, religious affiliation. So within one person, you can see how each one of us has many, many different cultural identities, which is why it becomes very complex in terms of providing healthcare services. But the bottom line is that even 2 people who are from the same nationality, same race, same ethnicity, same religious orientation, are very different because they've had very different life experiences. They may have had some similar life experiences, but no two people have experienced the same thing over the course of their lifetime. Even two identical twins, who are the two people in the world who are the most alike, at least genetically, are different culturally in terms of their life experiences, their subjective reality, the things that they experience in their own life paths. So culture becomes a very complicated concept. But I think if you remember that each person is different from you culturally, that really is the key. Whether you think they're similar to you or not, don't assume that you have anything in common, because there's so much within group variation. There's so much variation within a particular spiritual group, within a particular racial, ethnic group, that you can't assume that there's anything similar with you than the person next to you who's from the same group. For example, I'll give you an illustration. Years ago, when I taught my first multicultural counseling course in rehabilitation counseling curriculum, 5 institutions ago, I had a student the first night of class, it was a multicultural counseling and rehab class, raise his hand and say, "I'm so happy to see a Black male professor. I've never had one in my entire educational career." And I said, "Okay, I can appreciate what you're saying." I said, "So let me ask you this. First of all, how do you know that I'm a Black male professor?" I asked the student this. He looked at me with this puzzled look like, "What do you mean, how do I know?" I said, "Yeah, how are you certain that I am a Black person, that I'm a male?" And he says, "Well, I'm looking at you." I said, "Okay, and what do you see?" He says, "Well, I see the hue of your skin. I see your physical structure. You look like a man. You look like you're a Black guy." And I said, "Okay, yeah, but you could be wrong, because every time you see something isn't exactly what it is. What you see isn't always what you get." I said, "But I'll give you that. Okay, so I'll give you that. I'm a Black male professor." And I said, "Okay, now that you've put me in those two boxes, Black male professor, tell me what you know with absolute certainty about me." He had, again, that puzzled look. I said, "What can you say with absolute certainty about who I am in terms of my cultural identity, now that you put me in these categories?" He, again, couldn't tell me anything. I said, "Okay, let's think stereotypically. I'm a Black male. Do I play basketball well? Am I a rapper? All those stereotypes that we have about Black men." I said, and none of those things are things I do. So if you were thinking that based on some of those very traditional stereotypes, you'd be wrong. That was right off the bat. They kind of got the idea that everybody's an individual, and just because I am a Black male, and I gave him that, I said, "Yes, I am," doesn't mean you really know anything about me. Doesn't mean you have the key ingredients to how to work with me as if I'm your service recipient. So you kind of have to get to know who I am to really be able to provide services in a way that would meet my own cultural identity. You got to know what that identity is. So you got to get to know something about me. You can't just assume that you know about me because you put me in a particular category. So culture is really, really tricky. It's simple on the one hand because we all have a sense about what it is, and it really is lifestyle, traditions, values, assumptions that we make through our own worldview. But it's also very tricky in terms of providing services to people and figuring out what people's cultural identity is. Some of them end up asking people to identify who they are culturally, because then you're asking the expert on themselves who they are in terms of cultural orientation. All right, so cultural competency, cultural humility, and cultural efficacy. These are the terms you see that relate to providing services. The one that's most traditional is cultural competency, but then you also sometimes see cultural humility and cultural efficacy. I call those the newer age terms. They really are conceptually pretty much the same as cultural competency, but with some slight subtle differences. Cultural competency really is the idea of providing services across cultural lines in an effective way. And really there are three main things that have to happen in providing culturally competent services. First of all, it's impossible to be an expert in everybody's cultural orientation. So forget about that idea. So really, to provide culturally competent services, what you really need to do is, first and foremost, realize that you yourself as a healthcare provider are a cultural being, meaning you have a certain worldview, you have certain assumptions, you have certain stereotypes that are who you are. And you have to realize that who you are culturally is different from the person providing services to. They have stereotypes, they have assumptions, they have a worldview. Who you are and who that person is that you're providing services to may be very different culturally. So there is the potential, at least, for collisions in terms of those worldviews. So you have to acknowledge that as sort of a second step. And then the third step really is finding a way to exaggerate and accentuate those commonalities. And we know from the counseling literature, at least, that the single most important way to be culturally competent is to actually build a strong relationship, a rapport, a therapeutic alliance with the person you're providing services with. Because with that strong relationship, that person is likely to see you as being sensitive to who they are. And so that's really what we're talking about, building that strong relationship and then finding a way to accentuate the commonalities between you and that person, realizing that you're different culturally, and then providing services in a way that don't disrespect that person's cultural orientation, who's the service recipient. So you have to know something about who that person is to make sure you don't disrespect that orientation. And that's really what it means to provide culturally competent services. Now, cultural humility is a similar concept, but cultural humility says, okay, it's really much more about less of a destination. Competency says, okay, you sort of arrived at being competent. Once you are culturally competent, then you sort of arrived at a point of being competent, and you now know what you need to know to provide services. Cultural humility says there is no destination. You can arrive at being competent. It really is much more about continuing to strive to learn more about culture as you go forward. Learn more about your own cultural orientation and learn more about the cultural orientations of the persons you're providing services to. So when I think about the literature on these concepts, cultural competency, at least in the counseling literature, was the seminal work was 1993, Arredondo, Sue, and McDavis. Cultural humility hit the landscape in 1998 propagated by Tervalon and Morey. And then cultural efficacy came along in 2000. A physician by the name of Ana Nunez promoted this concept. And Ana says that efficacy is similar to competency and humility, but it really means that that there's a level playing field. Again, you have to constantly learn about culture going forward, but that Nunez said that sometimes people who are culturally competent assume that their culture is the dominant culture and the culture that they're trying to learn about is the less dominant culture. Anna says, no, it's always a level playing field. All cultures are on par. There's no more dominant or less culture. They all are the same, and that we have to continue to learn about that going forward. So cultural, what you want to call it, cultural competency, humility, or efficacy, it's basically the same concept of understanding that you're who you are culturally, what your biases are, that you have a different worldview from the person you're providing services to, trying to anticipate those potential points of collision, and then avoiding them by building that relationship and providing service in a way that respect the service recipient's relationship, the service recipient's worldview or cultural orientation. So I tend to still use cultural competency quite a lot because most folks relate to that concept because it's the long-standing concept in the literature. So humility and efficacy are much more newer concepts, even though they're basically the same thing with a little bit of nuance difference. Okay, cultural bias and mitigating it. So one of the things about providing services across cultural lines is that you have to realize that we all have biases. A bias is really just a preference or a dislike. So for example, I have a bias in the direction of diet. I drink a lot of diet sodas, so I like Diet Pepsi more so than I like Diet Coke. That's a bias. I prefer Diet Pepsi. I'll drink Diet Coke if Diet Pepsi is not available, but I prefer Diet Pepsi over Diet Coke. That's a bias. It's a preference. It's not a particularly dangerous bias in terms of providing healthcare services, unless you think I drink enough Diet Pepsi to really impact in a negative way the bottom line for Coke, if you're a Coke stockholder. But for the most part, nobody cares that I like Diet Pepsi or Diet Coke. But if I had a bias in terms of liking certain type of persons or disliking a certain ethnicity, if I said I don't like people who are members of this particular spiritual group or another particular racial ethnic group, then that would be a dangerous bias as a healthcare provider because I'm likely to encounter those people, and then I'm not going to be able to do my best work to give them the services that they really deserve in terms of effective and beneficial services to them. So really, we have to begin to think about bias from the perspective of what are our biases? All people have biases, and then you have to go through a process of really thinking introspectively to identify those biases and then evaluating each bias that you have in a way that allows you to determine whether it's something that can be addressed and whether it's dangerous or not, and whether you need to contain it. So what I suggest is you go through a process that says, first, I have a bias, whatever it is, by thinking about who you are, thinking about what kinds of things from a cultural perspective get under your skin or push your buttons. And say, okay, so I have this particular bias. For example, when I did counseling services, I didn't particularly like skinheads or white supremacists. And so if I was, or child molesters. So if I was asked to provide services to a person in one of those two categories, it'd be better for me to refer that person to one of my colleagues to provide services because I would be compromising my effectiveness because of my bias. And no matter who you are, you deserve to have the best services possible delivered to help you with whatever your challenge is. And so that would be a bias of me. So you think about what your biases are in terms of cultural issues. And then as you identify each one, you think about, is this a bias that's dangerous or not? If it's not dangerous, don't worry about it. If it is dangerous, meaning it could contraindicate you being effective in a given clinical situation, then you want to think about whether it's changed. The next thing is to think about whether you can change it or not. Some biases can change based on exposure, increased awareness, and more knowledge and education and understanding. Some biases never change. And no matter how much you get exposed to it, it's a deep-seated bias. I probably will never like to provide counseling services to child molesters, no matter how much I try. So if it's that kind of bias for you, meaning it's not changeable, then what you want to do is make sure you come up with a containment plan that mitigates it. So if it rears its ugly head in a healthcare service delivery situation, how are you going to make sure it doesn't compromise your ability to make sure the service recipient gets what he or she needs to get? And in some cases, it's as simple as referring that person to somebody else, or having aggressive supervision to allow you to help you work through that as you're working with that person. So we all have biases, and that's the key. And we got to think about those. And over the course of our entire career, we think about what our biases are, because they can come and go, because we change a little bit as we evolve and develop as people. And then we come up with a plan that allows us to identify the bias, determine whether it's dangerous or not, determine whether it's changeable or not. If it can change it, change it. If it is dangerous, if it can't change it, then we got to contain it somehow to make sure it doesn't get in the way of us being an effective healthcare provider. Okay, number 4, human beings and cultural difference. I always talk about this just a little bit because I like to really have people understand that as human beings, we're not really wired necessarily to do well with cultural difference. Now, let's talk about two processes. One, Piaget, many of you will remember cognitive psychologist Piaget, who talked about this concept of cognitive schemas. Those are the categories in our brain that from the time we are born and begin to experience the world, they help us sort and order what we see in the physical environment. So think about a young kid who's growing up, like a toddler, for example. They ask lots of questions about what things are. What's this? What's that? And their parents or whoever tells them, that's a chair, that's a table, that's a car, that's a dog, that's a cat, whatever it is. And they're learning. And as they're learning, their brains are looking at these things on a subconscious level and thinking about what those physical attributes are, so that they develop a category in their brain that allows them to know what a cat is, what a dog is. So the next time they see that same object, they have a general idea of what it is. And so cognitive schemas are very good, because without them, our lives would be totally inefficient. You'd have no way of knowing from birth all the way through adulthood what things were, because you'd have no categories already formed in your brain that tell you what the physical world is around you. So thankfully, we have these schemas, and they change, but they don't change very easily. So for example, if you're accustomed, if you're a 3-year-old and you understand that the table has 4 legs and it's got a flat top, and then you suddenly see a table that has 6 legs, your cognitive schema is not necessarily going to tell you, oh, that's not a table. It's going to say, oh, I think it still is a table, just a strange looking table. So you can see how that sort of perpetuates itself. Those schemas are hard pressed to change because our bodies are homeostatic and we do that which is most efficient. So if we can maintain a schema, then we don't change it. Only if it's dramatically different do we have to develop a brand new schema in our brains. So you can see how things like stereotyping can really get going because it's based on our past experience in terms of what things are in the physical dimensions. So that's the schema. And so let me give a good example of cognitive schemas. If we were all in the same room right now, of however many of us it is, 5 or so, I'm not sure who all's on the Zoom call at this point, and I said, in the next 5 minutes, we're going to have some people from Mars, let's say they're people on Mars, who are going to join us in our conversation. And when they join us, each one of them is 9 feet tall and deep purple in color. And we talk to them about what we're talking about tonight. And we say, yeah, we work at Downstate, and they work at a similar institution on Mars that serves people with, all kinds of healthcare challenges. And then they say, okay, see you, we're going to go. And then I say, okay, so next month when we have our next lecture 7 in this Dean's Lecture Series, I said, guess what? We're going to invite 2 or 3 or more of those Martians back to listen in. In your mind, what's going to be the picture of how they're going to look? 9 feet tall and purple. You see that schema's already developed from that one exposure. So that's how stereotypes start, because stereotypes are a very natural process. They're not bad. The problem is they don't generalize to everybody in the group. If I've only met 10 people from Wyoming and all 10 of those people have 3 or 4 attributes in common, then my natural inclination in my mind, in terms of cognitive schemas and my mind being efficient, is to think that everybody in Wyoming has those 10 attributes. But what it is It's a problem because that's a very small sample, and what those attributes are in that one sample may not generalize to the entire population, just like in a research setting. So that's the problem with cognitive schemas. They're fine and they work well when they work, but it's a very small sample that gets generalized too much to a broad population. So that's cognitive schemas. And really, it's about the categories in our brain that speak to what things are in physical dimensions. Now, in addition to that, we also have something called subjective reality. I kind of mentioned this earlier. That's our worldview. That's the sum total of our life experiences. So schemas on the one hand tell us what things are in terms of objects. Subjective reality interpret what they are in terms of what they mean to us. So if I held up today a Confederate flag, I'm willing to bet that every one of us on this Zoom call would be able to identify that as a Confederate flag, because the Confederate flag in the general United States culture is something that we all have the same schema on. We generally understand flags in general, large pieces of fabric with a certain shape, bars, stripes, stars on them. And I'm willing to bet we'd all agree, oh, this is a Confederate flag. But if I said, let's pass the flag around to people who live in different parts of the country, some in the deep South, some Republicans, some Democrats, some in the North, I'm willing to bet that they have very different interpretations of what that flag means based on their life experiences. That's subjective reality. People who are in the deep South, say Republicans, for example, might say, oh, it's heritage. It's about our historical heritage from the South. Black folks, maybe the Democratic Party may say, oh, no, it's about oppression and discrimination. So you see how that same object, even though we may agree with what it is based on its physical attributes, i.e. the cognitive schemas, we have a very different worldview about what it really means or its significance. So those two things together really come together and in a way compromise our ability to be effective in dealing with cultural diversity, because they kind of lock us in on what things are based on our schemas already in our head and based on our life experiences in terms of what things mean. And so we've got to work really hard in a very conscious way to sort of undo those things and make sure we're open to new things that we experience. Okay, social determinants of health. So these are the things that really relate to compromising a person's health status. And these are things like poverty, lack of education, lack of transportation, homelessness. These are social statuses that really are very influential in determining a person's health status. So if you are homeless and have no education, say beyond a third grade education, and have no transportation and no social supports, and you have a major health condition, those social determinants, those social factors are really going to be very significant in making sure that your health situation is even more severe than it would be if you didn't have those factors. So social determinants are those social indicators that speak to increasing the intensity of the challenge for a given health challenge that we're dealing with. So we know that people who are impoverished, who are compromised, who are underserved, who live in certain communities, who live in communities where there are food deserts, don't have healthy food options, have high unemployment, have high levels of poverty, have a lot of homelessness, don't have good transportation options. Those things actually complicate the health challenges that people have living in those circumstances. So in the absence of social determinants, people's health status is much easier to deal with. But the social determinants really make it much more complex in terms of having those multiple negative factors that impact one's health status, in addition to whatever the primary health challenge may be, whether it be high blood pressure, diabetes, or whatever it may be. So that's a very important concept to be aware of. And it used to be that when we talked about health disparities, we really did primarily speak of things like social determinants as being the reasons for health disparities. And they certainly do push along and increase the likelihood that health disparities will be very difficult to deal with. But we've learned in recent years that health disparities exist even without those social determinants of health. And so let's talk a little bit about health disparities. So the healthcare disparities or health disparities really speak to differences in the experience of having a health condition or disability. I do a lot of disability research that has to do with one's cultural orientation. In other words, who you are culturally adds a layer of complexity to the outcomes that you can achieve in terms of your health status. And so primarily, health care disparities focus on the outcomes. In other words, the Institute of Medicine did some work with the book called Unequal Treatment back in 2002 that spoke to looking at outcomes of healthcare services. In that book, they probably chronicle several hundred studies that held constant social determinants of health. So they held constant poverty, or socioeconomic status, whether a person has health insurance or not. And even in cases where those things are neutralized, those social determinants are neutralized, they found that you still see healthcare disparities in the outcomes of services across race and ethnicity. And what they say, the primary reason was because there are both systemic biases that speak to why the system itself doesn't serve all people the same way, or has differing levels of expectations around what people can do in terms of their health status. And there are individual clinician-driven biases that impact healthcare outcomes. So it's not an indictment of individual clinicians, but individual clinicians oftentimes have biases that they are not in touch with because they haven't done their cultural bias work, that are indicating and influencing whether or not they have the ability to provide services across cultural lines effectively. For example, you look at, take myself or take another person of white race and ethnicity and compare us together, say we're the same in terms of all the social determinants, but we both have, say, stage 3 cancer, prostate cancer, for example, and my outcomes are not as good as the white fellow's outcomes. And that has a lot to do with the healthcare systems having certain disparities, and my provider may have different expectations for me because he may say, well, I know Black men who have prostate cancer tend to die, and that subconsciously could impact what he's able to do for me or what he's willing to do for me, not on a conscious level, but a subconscious level. So we know that healthcare disparities exist even when we hold constant social determinants of health. But of course, when we don't hold them constant, because we only do that in research studies, in the real world, those factors also kick in to exacerbate the healthcare disparities. So the poverty, the homelessness, the lack of education, those things certainly do exacerbate the differential outcomes we see based on health status. I'm going to share with you real quickly a model I developed back in 2009, or actually a little before that. It was published in 2009. And this is a model that I call a disability disparities model. And because I do work mostly with disabilities. Disabilities are very similar to health conditions. They're a little bit different. Every disability has a health abnormality involved with it, but not every health condition rises to the level of being a disability. Disabilities, by definition, are permanent, and they have a major functional limitation that they impose. And we know that health conditions can rise to the level of being a disability if it's a permanent chronic condition, and if it poses a major limitation in a major life area, then it can be a disability, but not all health conditions are disabilities. And that's the difference between disability and health condition. But so my definition says a disability disparity, that is a difference in the experience of receiving services, including outcomes because of a disability, exists when an underserved or ethnic minority cultural group's goal is to receive services within the formal rehab and disability system, whether it be public or private. But there's a differential experience based primarily on cultural orientation that results in more incidents of disability and or lower participation levels in the formal helping system, and or fewer successful individual outcomes when compared to the majority group outcomes and participation levels and incidents. And so that's the definition that I posited. And of course, you can see right there, the assumption is that we want all groups to look the same in terms of their incidents, participation levels, and individual outcomes. So that's the weakness in the definition. I'm assuming that all groups have parity in terms of those expectations, which may not be true, but that's sort of the starting point. So it looks like a complicated model, and it is a little bit, but not too bad. So there are 3 levels. The top is really, it's 5 domains, because unlike the Institute of Medicine that looks primarily at outcomes, I'm looking at incidence, the occurrence of disability, contemplation about whether the group is going to actually receive services in the formal system. When they decide to receive services, what the access process is to get in the system, what the participation level is in the system, and what the outcomes are. So I've got a continuum of 5 different domains, and each one of these can be an area where you actually have a different experience based on your cultural orientation. So here I have what I call the hypothesized reasons why we see these differences across these 5 domains. And so the first one is with things like cultural and biogenetic traditions that differ by groups, intergenerational response to oppression, poverty, and social stress. That's different based on who you are culturally. Here's the ethnocentric worldview, that sort of that unicentric worldview that really plagues systems and doesn't give them the ability to embrace pluralistic viewpoints and values. Here, practitioner service system bias. conscious and unconscious values that contraindicate serving diverse groups effectively. So here are the reasons that could account for a difference in experiences based on cultural orientation across these 5 different domains on this continuum. And then here are just the concepts. Here are incidents, factors within the group that could account for higher rates of occurrence or incidents. That's the number of new cases in a given year. Group's perspective on disability as system engagement is pondered. I call that contemplation, because not every group that's different culturally immediately says, oh, you got a mental health problem, let's run down to the local mental health clinic and get your services. They have other things they consider, more indigenous options that they may want to consider based on their cultural orientation before they immediately access the Western approach. So let's say they do decide to access the Western approach, then the question is, what is the access process? How do they seek that help? And do they know the rules for entry into the system? Because every system has a set of rules that speak to how you actually access the system. That's the intake process. Then once they're in the system, the question is, how much do these groups actually participate in services? Based on the nature of the type of service that's being offered and whether or not they get an appropriate dose of the service based on how much they participate. So it's almost pointless to look at outcomes if the person hasn't been engaged enough from a level of participation to really have received a high enough threshold or dose of services to expect to see an outcome. So when they have, you look at the outcomes over here and you look at the impact of services within the group in terms of individualized benefit. So these are just the concepts, I call them macro level. And then down here, the micro level things that can be explored. So here are the things that researchers might want to look at. And then in the yellow level here, the micro level aspects practitioners can explore. So if you're thinking about an incidence area or disparity based on incidence or contemplation or access, participation, or outcomes, you've got a set of questions or set of areas, prompts that you can look into for a given client and think about what's going on with that person. So for example, here, lifestyle considerations, risk-taking behavior, in terms of the stress environment, self-medication, as in substance abuse that a lot of groups do when they're in impoverished situations, those kinds of things. Factors related to metabolic syndrome. Contemplation, you're looking at the group's view of the origin of disability, the group's view of what disability progression actually is with and without intervention, and the group's view of what typical interventions are efficacious for them. And again, a lot of this is mixed with what their indigenous beliefs are, and not always do the groups necessarily wholeheartedly embrace the Western perspective. Access, role of socioeconomic status and access. Do they have insurance? Do they have the wherewithal to actually access the formal system? The group's culturally driven help-seeking tradition. Groups seek services in very different ways based on cultural orientation. I'm reminded of an experience back in mental health many years ago when we had an intake worker who had a group of literally 12 family members who came in for the intake appointment, for a mental health intake appointment, and she was accustomed to 1 or 2 people coming, either the client and the client's significant other or parent or whoever, but not 12 people. And this group explained to her that, oh, we're from XYZ ethnicity and we do everything in a very communal kind of way. So everybody here has something to say about Johnny's problem with mental health functioning. So everybody seeks help in a very different way. An interaction between the rules of system entry and the various groups' help-seeking traditions. In that case that I just referred to, the intake worker was accustomed to 1 or 2 people showing up and speaking to what the issue is. But when a dozen people showed up, that person was totally overwhelmed and wasn't able to cope with that situation because there was a disconnect between the way that people typically access the system and the way this particular family decided to access the system. So you can see there are differences in help-seeking there. Over here, participation, strength of the treatment alliance between the client and provider. In other words, how much trust there is. Provider's ability to meet clients' cultural expectations, and amount of engagement. In other words, is there enough dosage? And so this gets into some of the cultural competency stuff we talked about earlier. And then over here, the extent the outcomes align with culture, again, cultural competency. Outcomes must be adjusted for different beginning severity levels, because sometimes people come in with the person with stage 2 cancer and a person with stage 5 cancer start at different places. So you can't necessarily compare those outcomes. You have to adjust for differences in severity when they begin. And then the extent the outcomes are measured using both objective and subjective measures, which gets into some of the outcome measurement kinds of stuff. So this is a model that I think could be helpful for clinicians and researchers who are doing work to look at disability or health disparities and understanding that these can occur across a 5-point continuum that speaks to the entire experience of being in the healthcare system. The incidence that allows you to have to access the system, whether you're going to access the Western system or use an indigenous system based on how you contemplate that. if you do access the formal system, how you do that, how much you participate, and what the outcomes are. And so back to our other sheet, the final thing, I know we're pushing time here, is I want to mention that early on, I said one of the best things you have to do, one of the most important things you have to do is try to make sure you understand how the person who's your service recipient, client, or patient identifies her or himself. And so I developed a tool back in probably 2006 called the Lewis three-dimensional model tool. And it's a tool that's its purpose is to be designed as an individualized tool based on each clinician's population they work with, how they understand the three areas that the model measures, and then it has to mesh with their own clinical orientation in terms of the style of interacting with patients. So the three dimensions are cultural identity, developmental functioning, and what I call a disability adjustment is. In other words, the outcome of services they're speaking to. So those three dimensions are in the tool that the clinician has to develop to help guide how they get to know who people are. So this ends up being, once you have developed your tool, a interview prompt that allows you to, each time you meet a brand new service recipient, to ask a series of questions that reveal information on that person's cultural identity, how they're functioning developmentally, and what their goal of treatment or therapy actually is. And armed with that information that you've collected by invoking this tool that you've created to mesh with who you are clinically, you have a better chance of providing services that are more culturally competent for the person you're providing services to. So with that, I'm going to stop. We're past our 30 minutes and open the floor for conversation. I know I had to kind of speed up at the end there and kind of pick up the pace with the talking. So questions, comments, points, observations, agreement, disagreement, whatever it is. Floor is open.
Question, Alan.
Yes.
Can a clinician or practitioner truly have or deliver competent care if they don't understand their own cultural biases? Or you mentioned earlier about unconscious bias versus conscious bias. If someone does not understand what those are, can they truly deliver cultural competent care?
Yes, but it's only by happenstance. It's a luck situation. So it's much, you're much more likely, your probability increases to the extent that you understand who you are culturally, what your biases are, that you're a cultural being, what your worldview is, and how those might intersect or potentially collide with somebody else's worldview and values and biases. And then you work to sort of, when you have a particular client, you work to sort of get to know who that person is using a tool like the Lewis three-dimensional model tool. And you then promote the commonality between the two of you in terms of what things are you have in common. We have a lot more in common typically than we have with different cultures, and then build that relationship that really makes it more likely for that person who's a service recipient to think that you have done a good job of providing culturally sensitive or culturally competent services. So it's not about ever studying and trying to be an expert on all the cultures you're going to have to provide services to. And there are some textbooks that get into that. I've used some of them in my courses, and I tell students all the time, I say, look, this book is going to tell you, if you meet a person from Southeast Asia, here are the things you always do, and here are the things you never do. I said, that is information that you never want to have to use, because there's so much within group variation that's going to fail you. So far better to collect the data on the person you have in front of you, who's the expert on who he or she is, get to know who they are, and forget about that textbook prescription or recipe about how to serve people. Now, if you're ever in a situation, which you are sometimes of providing services to persons with disabilities, where the person can't tell you about themselves, they're not able to give you information that you can glean about who they are, then you go to the default, which is, let's look at the textbook based on this person being in this particular group. These are the things I think may be helpful in providing services to this person. But that's the only time you use with that textbook default information. Far better to collect the information anew from the person in front of you who is the expert on who he or she is, in terms of they know who they are culturally. And if you ask the right questions, you can reveal that. They know how they function developmentally, not on their own, but if you ask the right questions, that'll be revealed. and then you know what they want from services in terms of the outcome they're seeking if you ask the right question. So you got to put enough time into developing a tool like this Lewis three-dimensional model tool that allows you to explore that with every brand new client you're working with, so that you can collect the data and reveal the information you need to put together the best treatment plan that allows you to be viewed as being culturally competent and helps the client get the outcomes achieved they want. In addition to knowing your own biases and that you're a cultural person. Because as you begin to deliver the plan, the game plan, you've got to make sure that you don't do anything that disrespects the person's culture who is the service
Right.
as much as possible.
Thank
So
you.
cultural competency is much more, it's not simple, but it's not as complicated as everybody becoming an expert in every culture orientation that exists on earth, because that's impossible. But some textbooks, at least some of the old textbooks, will lead you to think that that's the answer. You know, they have a long list of things. If you meet a person in this group, here's what you do. Here's what you never do. This group, here's what you do. Forget that. Figure out what you need to do by getting to know the person who's right in front of you. That's the expert. That's the person that knows who they are. Other questions, comments, thoughts?
Just a thought, Alan. There's been so much information coming out in competence, cultural competence in the past 3-4 decades, but how much quantifiable progress have we really made toward using these principles, using these concepts toward patient safety, and even more so in reducing health disparities?
That's debatable. It depends on who you ask, depends on which study you look at. We still have a ways to go, because the reality is that the world is becoming more and more culturally diverse as we go forward. And so sometimes I talk about the business argument for providing culturally competent services. And that argument goes like this. Each one of us lives in an era of accountability. We typically have more demand than we have resources to meet the demand. So what that means is that as a healthcare provider, you cannot afford to provide services that are not effective to anybody. And because the people that we're providing services to are not only greater in number because the population is growing, they're also more diverse in terms of cultural orientation. So you got to have a better understanding of culture and better tools to deal with culture, because you can't ever afford to not provide services that are useful to the people that you're providing services to. Otherwise, you're wasting those resources. So the business argument says we have to be better, increasingly better going forward with understanding culture and providing services that embrace who people are culturally and then meet the outcomes they need. But so it's sort of like cultural humility and ethics to say that we're constantly striving to do better in this way. And we're more aware, we have more tools, but many people are not using them. So the question is, how much of the workforce, how many healthcare providers actually have the understanding they need to have to really make good on the tools that are available to them? Who knows? Again, that's up to the results of whatever study you do that looks at that, and who you ask. So we still have a ways to go, because we still see very stark differences in health outcomes based on cultural orientation, race, ethnicity, all the social determinants of health. All those things speak to different levels of outcomes in various groups, and that has not changed appreciably over the last 3 or 4 decades. Yeah, it's a big challenge.
It is.
Gotta keep after it. We can do better, but keep after it. The one thing is better is that systems now a little bit better understanding, looking at clients more holistic. And when I started working in mental health back in the early to mid 1980s, if you accessed the local mental health clinic, you had to decide, or the intake worker had to decide what issue you had, because the system was not good at understanding comorbidity. So if you came in and you had a mental illness and a drinking problem, the mental health system at that time had to decide which of those challenges was really the primary challenge, because they couldn't deal with both at the same time. We now know that people are holistic, and we have all these social determinants to deal with, and we have all these comorbidities to deal with, and we're able to look at people more holistically in terms of the challenges they're dealing with. And the systems have been able to become more flexible in seeing people as holistic beings and providing services that deal with these challenges sort of concurrently. So that's improved. And the systems also have become a little more pluralistic in their ability to understand different worldviews. But we still have a lot of what's going on, like the intake work I talked about. That was back in the early, probably the later 80s, when she had that experience where she was not prepared for a family of 12 to come into her office and say, oh, we're all here for the intake appointment. She's like, well, what are all you people doing here? I just want to see the client and maybe one other person. They say, whoa, wait a minute. We're all the family and we each have something to say about what this person's needs are and how he or she is functioning or not functioning. And so she was taken aback by that. But that was that group's help seeker tradition. So the systems now are a little bit better about being flexible in that regard in terms of being able to do that. But historically, all of our formal systems in this country are primarily developed to serve white men. Now that we have a population that is inclusive of all kinds of people, those systems have to be changed going forward, and they're changing a little bit, but incrementally so, and not dramatically. So,
Alan, I guess I'm thinking, and largely, as you know, the master's project group and spurred me on through our accreditation process to look at this, since obviously we're required to be able to turn out culturally competent clinicians.
right.
And so we're challenged now to bring it back into the classroom. Like we're a step before you. So before you can use these tools, like have them use them as clinicians, how do I make our students more culturally sensitive to become culturally competent clinicians?
Right.
And that's really challenging to me at a master's level, because they've come thus far through their undergrad education, and probably, many of them have not dealt with these issues or brought it about. So the sensitivity that I need them to bring to the clinics is not there.
Right.
And it's hard, it's not something that you can really, or I'm struggling to figure out how maybe to teach it or bring it into the classroom in our curriculum.
So there are a couple ways to do that. So I did an article, I think like that was in 99 too, that looked at infusing culture to every course. Traditionally, what healthcare professions have done is they've had an identified course. That's the culture course that everybody's required to take, but all the other faculty who teach different courses say, okay, go to the culture course and learn about culture and cultural competency and who you are as a cultural being, your biases and values and all this stuff. And that's where it is. It's self-contained in that course. And like the course I mentioned early on, when the fellow said he was happy to see a Black male professor, that was the culture course in that particular curriculum way back then. But what's happening more and more, and what needs to happen even more so, is that people who put these curricula together need to have a way of infusing culture into every course. So
it's got to be integrated.
It's not just the one course, that's the culture course, the designated culture course. You have to have a way of infusing culture into every course that's taken. No, I don't, even human gross anatomy. There's a place for culture in that course as you're looking at these cadavers and seeing what the differences are based on race and ethnicity. So there's a framework that I developed, a 4-step framework that allows a faculty member who's teaching a course to go through a series of questions. And if they answer those questions honestly, it gives them a guide for how much culture can be infused into their course and the kinds of strategies they can use to actually make a difference. So whether you're teaching, therapeutic practice 4 or master's project 1 or gross anatomy or whatever other course you're teaching, there's a place for culture to be infused in all those courses, but you've got to have the wherewithal to make that happen. You got to have a motivation by faculty to actually do the work. And that's what we are not doing yet across the board. And then you've got to have a way to have what they call immersion experiences with culture. So when they go out to their clinical placements, they have to be able to be thrown into a clinical situation where the cultural piece is very prominent, and they're evaluated based on how much they're dealing effectively with the cultural differences as part of that immersion, that clinical immersion experience. So I can send you the article that I wrote 2019.
That would be great. I was just thinking about that. I'm also wondering, and I could be really out in left field here, if as soap, how we have certain like all soap days of, different things, would it be appropriate to have a day of that kind of cultural course, like you're saying, for all of soap, and then put it, for the faculty to follow up within all their coursework?
Right, absolutely. And Shoshana can actually speak to, early on, one of the things we talked about doing was doing a study in our school that looks at how much culture is actually infused or integrated into our current courses right now as a baseline, and then using that approach that I referenced in that from that publication to teach faculty how to infuse culture into all their courses, and then do a post-test down the road and see how much we've changed in terms of that. And Shoshana, I mean, I don't know where we are on that. I think they kind of got derailed with that with the
Got
pandemic.
derailed.
Yeah, like a lot of things got derailed.
So Alan is ahead of his time. Yes, Alan had charged Bridget and myself to do a survey across the 6 disciplines in SOAP. And that was the baseline survey. And we did recognize that culture was not consistently being taught. It was infused in some courses, but not across all. So the next step, as Alan mentioned, was for us to do some sort of intervention, which will be, I think it was a course that you were going to teach, Alan.
Right.
And then do a post-test following that workshop or course.
Yeah, and then publish it so we get some research.
Correct.
Right.
Out of it too. But yeah, but we have a lot of work to do, Nancy, in terms of this kind of thing, because I mean, it's not just us. That, you know, all the healthcare disciplines are doing very little. I mean, they have their dedicated course, but beyond that, we're all failing in terms of really making it a more integrated concept in everything we do. And we've got to do much better with that.
That sounds interesting. No, I agree. I mean, the master's project group is just going to look at using a tool. So again, we have, you know, pre-data before a course and post after the course throughout the OT curriculum, starting hopefully in the fall, you know, what the students get. But the faculty has had essentially no, you know, structured training and how to bring it in. So it's kind of like we're picking up a piece of what you wanted to do, which will give us some data if Shoshana, you know, you get the other study put together, because then we can sort of redo this tool, like, all right, the students came in this way, gained a little bit along the way, but not enough. And then once the faculty becomes more knowledgeable, you know, are we then infusing it better? Are the students coming out more culturally competent? Would be a really cool little study.
Right. Absolutely. We could probably do a couple studies.
Yeah.
We just have to do it, you know. Again, this was something we had a little bit of momentum on doing prior to the spring of 2020 when the pandemic hit. And then, you know, this kind of thing kind of gets kicked to the curb, so to speak, with everything else we had to deal with to keep the railroad operational, so to speak. But yeah, we can get back to it.
Thanks. And if you could send me that article, I'd love to take a look at it.
I'll send everybody who's here today can take a look at that. I'll send the article that talks about the model that I just talked about, the disparities model, as well as the, it's called Integrating Cultural Competency into Rehabilitation Curricula in the New Millennium. Keeping it simple, is the name of the article. So yeah, it talks about a number of different strategies.
Thank you.
You're welcome. Other comments, observations, questions, points of agreement, disagreement, whatever it may be from anybody? I'm going to unshare my screen because I can't see who's here at the moment. At 10 people, okay. Yeah. Other comments, questions? It's a big area. Culture and health disparities, you know, intercultural competence is a big area, but it's a very important one, and one that's here to stay. You look at how much the populace in this country is growing in terms of absolute numbers, and then look at how much it's changing in terms of becoming more diversified. And then if you take the point which I made early on, is that it doesn't matter about the traditional dimensions of culture. If you just look at each person as being different from you, which in fact is the case, then no matter who you're providing services to, you have to assume that the person you're providing services to is different from you culturally. They have a different set of life experiences, they have a different worldview, different assumptions, all those things are different. So you've got to think about that in every situation, not just the ones where you say, oh, this person's obviously a different ethnicity or race than me, but really every situation requires us to have that cultural orientation where we think about how we can provide, getting to know who that person is in terms of their identity, what they want from the service encounter in terms of outcomes, you know, how are they functioning right now, and then trying to build that relationship so that we can meet their expectations and not disrespect who they are culturally in providing services. And know who we are and who they are, you know. It's a lot of it has to do with understanding yourself and what your limitations are. We all have them, even though we're highly credentialed and trained and educated and smart people. We still have, as human beings, we all always have some limitations. Nobody works with everybody optimally. So got to kind of come clean with yourself in terms of understanding that. Other comments? Let's see, looking at the clock here, we're right at 6. Okay, well, thank you very much for joining today. And remember, all these sessions are recorded. So if anybody wants to see them who wasn't able to attend, they can contact Franchon. Franchon can give them the information on the website where they can go in and see whatever they've missed. And we also want to do an evaluation. So Franchon can give you the evaluation so we can have some feedback on how well we're doing or not doing going forward in these conversations. Thank you very much, and hopefully can see you next month at our, I think next month we're talking about either social capital or values-driven civic engagement. I forget which one it is, but one of those two.
Building
Everybody-
social capital.
Building social capital, yeah, okay, networking, okay. Great,
Thank
Okay.
you, Alan.
thank
This
you,
was a good
everybody.
session. Thanks.
Thank you, be safe and everybody do well. Thanks.
Okay.